A few weeks back, I looked at the AbbVie paper, the one that went through around 600,000 real work conversations across almost 200 different jobs. And what that paper really was, at heart, was a map of how wide AI has spread inside one company. They looked at it horizontally across the whole organization, every function, asking where AI is actually turning up in the work. AstraZeneca just put out a paper that's almost the opposite. AstraZeneca is obviously using AI all over the place too, but here they are not doing the company-wide sweep that AbbVie did. They went vertical instead, more depth into one specific scientific workflow, showing what it looks like when you wire language models straight into the data and the tools scientists use to do drug discovery. So one paper goes wide, the other one goes deep. And read together, they tell you a lot more about where enterprise AI in pharma really is than either one does on its own. So the paper I'm talking about today is called Research Assistant, AstraZeneca Agentic System for R&D. It has 19 authors, and the corresponding author is Piotr Grabowski, the technical lead. The number everyone's going to grab is this one. It went from a tiny pilot to 15,000 unique internal users in about a year. This didn't start as a grand plan to build an autonomous AI scientist. It started with 3 people experimenting with GPT 3.5, so that's already quite a while back, as a chat interface on top of AstraZeneca biological knowledge graph. And the problem they were solving was pretty mundane, but important. The company already had these sophisticated scientific database, but to use them, you had to write Cypher queries or hit REST APIs. Most scientists can't do that, and to be fair, they shouldn't have to. The language model isn't really the product. What AstraZeneca actually built, the real product, is all the scientific data underneath it. The API, the ontologies, the knowledge graph, the retrieval system, years of data engineering. The model is just becoming the interface, the thing sitting on top that lets you reach all of it in plain language. And that matters because it changes what we even mean by AI in pharma. A lot of the intelligence people get excited about is really that unglamorous back-end work AstraZeneca had already done. The model just made it reachable. You can finally ask a question like a normal person instead of writing a query. So how does it actually work? There are 2 modes. The first we call scientific mode, and it's fast. You ask a question, a router works out which tools are relevant. Those tools all run at the same time in parallel, and then a bigger model pulls it together into one answer with citations. Quick, 10 to 30 seconds, about 60 cents a query. The second deep research mode is the more genuinely agentic one. It writes itself as a research plan, basically a graph of questions, where the later one depends on what the earlier one found. A judge agent checks the plan before it runs, then it works through the question in order, rewriting the later one using what it picked up along the way. Here is very important hit. Notice where the ceiling is. This is still bounded. It's orchestrating searches. It's not designing its own experiment. It's not pushing compounds forward without anyone reviewing it. What they built is an agentic information system, not an autonomous scientist, although one might lead to the second one. The difference is basically the whole thing, because the word agentic in the title can lead you to imagine something far more independent than what this really is. If there is one lesson to take from this paper, for me, it's this. As they went from prototype to production, they gave the model less freedom, not more, which is interesting, because that's the opposite of what you would expect. Their first tool router used embedded example question and picked tools by similarity. They dropped it because a nearest neighbor search always hands you back something, even when the match is terrible. They replaced it with something that uses real usage data to define a stable set of topics. Let the model do the high-level sorting, and then the developer decide which tools go with which topic. Same story with the knowledge graph. They tried letting the model write its own Cypher queries, free form. It went badly. It picked inconsistent paths, You lost track of where the answer came from, and some query just timed out. So they locked it down, ground the entities first, project a schema, built a prototype query, then apply fixed rule about which data source you actually trust. So the pattern is really consistent. Use the model for the language part, the messy, ambiguous human part. Use plain deterministic software for the part where you need consistency and you need to know where the answer came from. And that's a much more grown-up picture than the fantasy of one all-powerful agent that just does everything. The section that will get the least attention is the one I think is the most important, and it isn't the chatbot at all. It's a patient safety workflow they call CRAM, Combination Risk Assessment. When you combine two drugs, someone has to work out whether the combination creates new safety risks. That used to mean a scientist sitting here, opening the assistant, manually typing a whole series of questions. What pathways are involved in nausea? Does EGFR play a role? What about EGFR inhibitors? And so on. Now the CRAM tool calls the research assistant on its own programmatically. No human typing anything, the workflow hits the API, gets grounded evidence, back with citation, and drops it into a structured safety table. That for me is the moment it stops being an app and starts being more like infrastructure. It becomes a thing a system just calls, which is also why they expose those REST and MCP endpoints. They are building a scientific evidence layer that future tools can plug into instead of everyone rebuilding the same data connections over and over. Now the part where I have to be straight with you, because this is where the paper is, I think, a little bit weaker. Follow the chain and it runs infrastructure, then access, then reach, then repeated use, then workflow integration, and then a whole row of question marks. Does it make people more productive? Does it improve the quality of decision? Does it change R&D outcomes? Does it help patients? We don't know. The paper doesn't really answer any of it. And maybe that's not the point of this paper. And that 15,000 number I told you at the beginning, that's the reach number, not an adoption number. It can't tell you how many of those people came back after the first try, how many use it every week, or whether a small handful of power users are doing most of the work. Someone who opened it once out of curiosity and someone who lives in it all day both count as one user in that figure. There are really scientific risks in here too, and the authors are honest about them but don't fully test them. Putting out single sentences is efficient, but a sentence can lose its context. Was that finding in mice or in humans? Was it a real result or a throwaway line in a discussion section? Ranking the literature by citation count can bury the new stuff, the niche type of research. And that discover agent, the one that proposes a relationship and then goes off to find evidence for it, carries a real confirmation bias risk if it doesn't look for the contradiction evidence just as hard as the supporting evidence. I'll give them credit though. They name most of these problems themselves, and that's the real strength of this kind of paper, and this paper in particular. It's honest about production. It talks about latency, cost, the routing failures, the queries that broke, and the fact that having a citation doesn't actually mean the claim is true. That kind of honesty is rare and it's interesting. And I think it's extremely important for the rest of the industry to learn. So that's the whole value of this kind of paper. And let me bring it back to where we started. So we talked about AbbVie. So AbbVie gave us the wide view of how AI is used across the organization. AstraZeneca gives us a deep view, AI going right down into one series of scientific workflow wired into the real data and the real tools. But put them together and the message is quite clear. Enterprise AI in pharma is real now. It's being used and it's getting properly built into how the work happens. Both papers hit the same wall actually. They show that AI has entered the work. Neither one shows that the work and eventually the science got measurably better because of it. And that's the paper I actually want to read next. Not another architecture diagram, an outcome study. The same workflow with the same assistant with and without it, measuring the time, the quality of evidence, the error rates, and whether the decision downstream actually improved. So until someone publishes that, what we are watching is the industrialization of AI in pharma, which is a genuinely big deal. And we are still waiting on the proof that it makes the science better. I think it does, I hope it does, but this is the next thing that we actually need to measure.